sensory activation is independent of the type of the perturbation or the direction of when the perturbation occurs. And therefore, it acts symmetrically as a corset early in, before real movement happens, to stabilise the spine. The inference of this is that in the absence of a feed-forward response, it is inferred that there is a decline in the ability to stabilise the spine. Now, this belief system can be held as much as you want, but I think in terms of research, a lot of PhDs have been set up with this premise, and therefore they are making other follow-on arguments which don't necessarily make sense. So I'm going to give a series of take-home messages because some of this is a little bit complicated and I have to balance between clinical and research. So let's have a couple of questions. Transversus abdominis, how many muscles? Singular or plural? Transversus abdominis muscles, there's actually a left and a right. So like other muscles, we tend to have this mental construct that transversus abdominis is a single muscle because we never say left or right. So we have a propensity of describing it as a single muscle. And I had a few discussions with people and they said, well, that's true for genioglossus, it's true for platysmus. I can't do that, but I saw people last night trying to do that. And someone did point out levator ani, but I'm not talking about that today. The assumption, interestingly, of the functional asymmetry is that any asymmetry would actually represent a dysfunction or a neurological absence or control. And so we have to think that this is not necessarily how it happens with transversus either. So there's a series of papers that we're doing. As I said, we wrote a couple of papers. These haven't been cited a lot, so I suspect the understanding or belief of what we did is questionable. That followed with a sort of a commentary, and this was the most downloaded paper for that month in British Journal of Sports Medicine, and the response by the following month was even more downloaded. But this is the stop press. This is ahead of publication 2 weeks ago. Corset hypothesis rebutted. Transversus abdominis does not contract in unison prior to rapid transfer. So let's just start off. I'm talking about the mechanisms of what we observe in research. It is not about efficacy or diagnosis. And I'll make it very, very clear, is that our studies, if we were only to actually assess the left-sided transversus abdominis, ignore the right side, we are replicating what's in the literature, that it is a feed-forward response when we raise our right arm. So there's absolutely no conflict in our findings in that sense. Our questions are, however, what factors impact on motor control of the core? And there's been a lot of research, Lorimer Moseley, Paul Hodges, etc., demonstrated that anxiety, depression, etc., not so much depression, anxiety, stress, etc., can impact on the control of the transversus abdominis. Our question is that let's look at what mechanical factors can impact or choices of movement can impact on the feed-forward response. And we want to validate the mechanical loading. Second message. The central nervous system is responsible for the activation pattern. Transversus abdominis, like all muscles, has afferent and efferent connections to the central nervous system. Muscles do not have a mind of their own. Muscles do not have intent. It's the central nervous system. Anthropomorphism is a common problem of interpreting muscle function. We actually give attributes of intent to particular muscles. Some patients may think that they have an alien type of thing coming out of their stomach because their core isn't working properly in that rotten transversus abdominis. So in terms of physiology, form and function always interact. And although a muscle has a capacity to do something, it is the activation pattern that defines its function. So there's lots of studies that have demonstrated that transversus abdominis can stiffen the spine. Now, albeit, it has to work bilaterally to get that function, not unilaterally. And it has to work bilaterally, and it will actually impact mostly on flexion, resisting flexion, because it tends to extend. There's other mechanical models, and this is a recent one, or this is a one from early 2002, and this is a mechanical model to try to describe why the corset action can stiffen the SI joint. I actually, and this is the model, proposed model by Richardson et al., and it compresses the SI joint. I actually think that this mechanism works, but it's not necessarily via corset, because our study shows that the contralateral transversus abdominis is strongly linked to the other side, or the ipsilateral biceps femoris, and it is those ligaments and fascia that cross the sacroiliac joint which actually would have a similar mechanism to what's demonstrated here. So what does the other activities of transversus abdominis? Well, there's lots. Yes, intra-abdominal pressure plays a major role. It has an interaction function with the diaphragm, the pelvic floor, and the transversus creates a cylinder. Right? There's complicated interactions there. Can it move the spine? Yes, a little, mostly in resisting flexion. Of course, it extends the lumbar spine. Here's a study from out of Alf Forston's research just recently, and he got people holding weights. And if you look at this scenario, the person's holding a weight, they do this, and transversus abdominis increases, as does the extensors to resist the flexion moment, and also increasing the intra-abdominal pressure. So it could be having a dual role there. The next study, this is interesting. If you hold weights and you lift it up, that's how you increase transversus abdominis activity. So that's an interesting one. We believe that's because with the weights above the head and natural postural sway, they try to control rotation using transversus. But this will be the latest transversus exercise for everybody. So you've seen this before, and I'm going to go through it. We're talking about bilateral activation of EMG. What we did is that we inserted fine wires into both sides of a group of people, normal people. And if there's any of the reviewers in the room, no, they didn't have needle phobia. They weren't depressed or anxious, and the radiologist who inserted it was actually skilled to make sure that they got the right muscles. So when you raise your left arm, here's a summary. The red line down the center there, here is the onset of deltoid, so about from here backwards is a feed-forward response. When you raise your left arm, your right transversus comes on early and your left is late. When you raise your right arm, the left side comes on and the right is late. The amplitude changes. Interestingly, when you raise your both arms together, so minimizing rotation, we see the pattern that we believe happens in people with low back pain. It's symmetrical but delayed. Now, our results show that this is actually not a black and white scenario. There's probably 20% of normals who behave like low back pain, and we haven't done a lot of people analysis with people with low back pain. However, when we did present this, it was pointed out that, excuse me, if you look at those traces, you can see a feed-forward response of that muscle. So, Gary, you can't write a statement saying that transversus is not feed-forward, because there is an activation that comes on in the feed-forward window. Although it's a little bit less than the other side, it still does come on. So your idea of unilateral activation is a load of rubbish. And I respect that. The onset of the transversus abdominis, however, those peaks probably are 8, 9 times larger than the onset part, and the amplitude of those transversus activation patterns are about the equivalent of this. So 1/8 of that is when the onset comes on. So then this is about another 16th of that again. Onsets. This is out of the Joss paper. We fell down the pathway of looking at onsets and offsets. Lots have been written. If you look at this diagram, we did right arm, left arm activation, and you get asymmetry in all the muscles, except the muscles close to the central axis, as in rectus and the erector spinae. And there is a laterality, there is a directional specificity of all trunk muscles. However, onsets are a problem. And as I said, we made this mistake, and I think other people have as well. So one of the problems, take-home message, I think I'm up to 3 or 4, onsets tell us very little about mechanical responses. So the fact that someone delays 30 milliseconds of a 5% contraction, how does that really impact on the mechanical stiffness of the spine? Is 30 milliseconds significant? The other thing is that all of our algorithms have actually calculated when the EMG signal increases above a baseline. So a feed-forward or planning motor control theory is that we're looking at only excitatory patterns. But what happens if we see inhibitory patterns? 2 standard deviations above the mean isn't actually reflecting of a inhibition pattern. So we started looking at onsets and offsets and probably realised that it's a little bit more complicated than what we had thought. The question is the absence of an onset, is the only mechanical or motor control interpretation of that is that the onset is delayed, or is there an alternative? What happens if the muscle is an offset? Here's a couple of traces of the contralateral transversus abdominis. So in this case, it's the left side. So I'm raising my right arm, and as I go to raise my right arm, transversus on this left side pre-activates. We all know about that. So this would be about my normal onset position. This is a reflected simultaneous collection of the ipsilateral side of the arm movement. It's just reflected so the lines aren't on top of each other. It's not that it's inhibited in that sense. But what we see is that if we were to calculate the onsets, we would see that this is a delayed onset on that side. We would equally argue that in a very large proportion of these people who actually move very quickly and very freely, that what we observe is that we observe an inhibitory feed-forward response. We see a remarkable, a silent period before the activation, which actually coincides with the activation on the contralateral side. This is known in most joints, biceps, triceps, quads, hamstring, is a reciprocal inhibition. So a reciprocal motor control pattern. So when we started observing this, we realised that our previous work on onsets wasn't really picking up what we're looking at. We can't really say anything about the feed-forward response. We can only talk about the feed-forward excitatory response, not the inhibitory response. So what's new? Well, the problem is that when we did all our onsets and things, we realised that onsets aren't very good. And so we need to actually look at how we can quantify the dynamic loading on the spine during rapid arm movements. The biggest weakness of our study, and probably I would say in general in the literature, is the inability to document the mechanical loads on the core and how these impact on the behaviour of transversus abdominis activation patterns. So we utilise 3D motion analysis to determine the torques acting in the trunk and finally work out what impacts on the behaviour of transversus abdominis bilaterally. Now, normal gait is that you step on a force plate and they look at your ankle and then your shank and then the leg, etc. And you do a kinetic chain calculation of forces. However, and most biomechanists know, you can actually do it the reverse way. You can start at the hand and actually work the way down. So what we did is that we got people to do this, and I'll show you diagrams, but we did three-dimensional inverse kinematics to calculate the rotary torques generated in the trunk, right? And in particular, the differences between the pelvis and the thorax, which we defined as the core. So we asked, what controls activation of the deep abdominals? So we did a mathematical model and we got people to do a whole series of different rotary tasks. And the reason why we did this left and right flexion is that we believe that the motor control strategy of doing arm flexion is not the inverse of just doing arm extension. Because this flexion can be a whole body action and extension is really quite difficult to do that. So we said, well, let's do a right arm and do a left arm. And while we're here with all these markers like a good researcher, why don't we do this and this? And why don't we give weights in their hands to see if they can do that with weights? We also had the bilateral arm raising. So if you do this, you're perturbing the spine, but there's no rotary component. So here are the different arm movements we did, and here are the torques. This is the axial rotation force acting across the core. And you know that if we raise our right arm, then there's an equal and opposite reaction of wanting to pull this way. We raise our left arm, there's an equal and opposite reaction going the other way. And you can see this continuation. When you raise bilaterally, right, we see that there's hardly any rotary torque. And in fact, you put weights in someone's hands, there's a slight bias towards their dominant arm. It means that it was moving slightly faster. They weren't very symmetrical. Did we generate axial torques? Yes, unilateral, you see that. And if you do it bilateral, there's no rotary torque. So there is validation in our method. So you've seen this diagram before. And what we did with this analysis, we did a principal components analysis, and this is what came out. The contralateral transversus abdominis, and we measured biceps and internal oblique and external oblique on all sides, that when I raise my right arm, the contralateral left side pre-activates, as the literature has said for the last 10 years. Prior to this activating, biceps comes on, and internal oblique comes on very similar to to transversus. When we did a principal components analysis, transversus on the contralateral side is more closely related in control to the internal oblique and biceps, creating this rotary sling in motor control, not a bilateral pattern. Fascial slings, diagonals, etc. is within the literature. It's understood, and we actually do a lot of that in sports therapy for rehabilitation. Simply put, people talk about Serapi muscles. We're talking about a diagonal rotary sling going from the biceps across the sacrum into the deep abdominals. To prove this, what we did is that we looked at a motor control method called reciprocal activation versus co-activation. Co-activation assumes that the control pattern is a bilateral left and right corset action. Reciprocal activation is calculated that the control mechanism, if one goes up, the other one has to go down, and vice versa. These next two slides are a bit complicated. I'll move through them quickly. This is not right transversus. What this is that this stands for reciprocal transversus motor control function. If we see a perfect reciprocal association, we will see this line. What this means is that here is the reciprocal function of the motor control pattern, and here is the difference in torques, doing all the different actions. We would say that the reciprocal action would be directly associated with the change of direction of torques. We would see that. If there's no reciprocal action, a corset, and it's not related to the torques, then we'll see a straight line. Here's the 6 subjects that we found, and what we've demonstrated is that not everybody does everything perfectly. It's not black and white. However, there is a very strong association between reciprocal control. We know that there are 4 out of these 6 people who have a clear motor control strategy which separates left and right transversus, and more importantly, reverses it when the torque changes direction. These people seem to have a co-activation strategy. Number 6 was a bit strange. Let's look at the co-activation. Is there any evidence that there's a co-activation strategy? If there's a co-activation strategy, as the torque increases, we would expect the co-activation strategy to increase. No torque, no co-activation necessary. As the torque increases in either direction, it should increase. If there's no torque, then it should be flat again. What we see, number 6 and number 3 again, are a bit problematic. Number 3 looks like they have a bit of a co-activation strategy. These other people do not. One point to remember is number 6, however, has a very interesting behaviour, is that anything under that line 0 is actually inhibitory. So this person tended to have a lot of transversus happening, and then when they go to move, they actually inhibit. So we later found out that they did a lot of work in core stability in their training. Here's a study. What they found is that when you do these activities, left and right transversus abdominis is biased in the amplitude. When you raise your right leg, when you're face up, your right transversus works more than your left. When you're prone, it goes the other way. This is an interesting study because what they did is that they asked those people to do these tasks with and without hollowing. When they did it without hollowing, there is an asymmetry, represented blue, where we see the left is less than the right, and red when right is more than, left is greater than right. When you ask them to hollow and do the tasks, what we see is that we see the same differences. The hollowing task does not change the asymmetry in our normal motor control strategies. What we do see, however, is that there's a baseline increase of both muscles. So it's increasing the tone of those muscles. How that translates into low back pain, it's not that clear. So what else impacts on timing of transversus abdominis? Well, rotation is the key factor in changing that. A delayed response in transversus may be associated with the movement, Bracing reduces the need to rotate. If someone walks around with bracing, then there's not going to be any rotation, so transversus doesn't need to come on. It is part of the strategy, the planning. People with low back pain may choose to move differently, subconsciously or consciously, appropriately or maladaptive. But it is their choice, the cognitive function, which impacts on their behaviour, which impacts on what we see in transversus. Fear of pain, anxiety, catastrophizing have all been shown to change these parameters. So why transversus? People with low back pain, anxiety or fear of pain, have a reduced degree of freedom, and the first degree of freedom that people lose is rotation. So that's why transversus is likely to be the best marker for this change in behaviour. People may lose their laterality response as well. Transversus is only the muscle that works across gravity and therefore is very related to rotation. So we have definitive proof that behaviour of unilateral transversus is related to choice of movement strategy and a resultant rotation torque. It's not normal to have a bilateral feed forward response of transversus abdominis independent of direction. Most cases we believe that unilateral transversus abdominis is part of a rotational sling, and that's what we should be training. Clinical practice, the rationale of the role of transversus should be considered as a whole body concept, a synergy, a sling, a diagonal. The brain is what defines how people move, and it can influence it in many ways. Trying to relate mechanical deficits to a stability, right, based on the timing and the amplitude of this single muscle is very problematic. I'd advise you to train the movement, not just the muscle. So in some people consider that rehabilitation has many phases. I believe that we should focus at the muscles, look at the movement, and then look at the task. Our outcomes should be based on capacity, endurance, fatigue, performance, diversity of motor control strategies. Sometimes you want diversity, sometimes you don't. In general, you need a bit of each. And then you have to look at the proficiency of these elements within the task that the person is doing. From elite athletes to people with stroke, this is the fundamental understanding. So this is our final publication in this area, and I'd like to thank people very much. Thank you.